Welcome to session 3 of analytics practice. Today we're going to talk about how to make good comparisons. And more than any other session in this series, we are going to spend a lot of time talking about how researchers think. And that can be, I'm not trying to make anybody a researcher, but we are all, we make these kind of comparisons and use these tools every day. And sometimes it's useful to raise our awareness about how we use them so we can use them with more precision. So first I want to do a little overview of what we talked about last time by reviewing notions of what a good intervention is. The first thing we talked about is the importance of developing an intervention in the context of a good knowledge base, understanding what has worked well in other places, what works well in our organization, and understanding kind of at the beginning what we want to learn. If there is going to be learning, we almost always want to learn something because we're always trying to improve one intervention on top of each other. So it's worth sitting down and trying to think through what is it we want to learn from this intervention. How do we know that we'll do a good job? What does success look like? Thinking about the time frame that you need results in order for you to learn what you need to learn and move on to the next stage. Sometimes we set up interventions with outcome measures that are so complex and have such a long time frame that the learning we need to do is out of sync with that. We really wanted to learn something new in 2 weeks, and the intervention, the outcomes we picked are going to take 2 to 6 months to surface. So we really need to sync our expectations about results and the time frame for the intervention. We also need to think about what stakeholders want and what demands they make on us and what they want out of the intervention. And then, of course, we need to think about what resources we have available to us in a real world, dealing with the reality of constraints that we're always under. And as I mentioned before, really thinking about every intervention in the context of long-term efforts and goals, not trying at all to just say, what do we want right now, but understanding that every intervention is probably part of a bigger effort down the road, and we want to be able to make sure that whatever we build today, we can build on for longer-term outcomes. Intervention theory is something we spent a lot of time on last time, and just want to recall that intervention theory is more prospective than some of the other ways of laying out what an intervention might look like, or kind of digging into what happened in the case of a key driver diagram. The idea is with an intervention theory, you're setting out a set of beliefs that could underline what action you're taking. They don't have to be correct. They don't have to be valid. They just really need to reflect what people think is probably going to happen. And it's better if those beliefs are anchored in knowledge and a deep understanding of the program, but sometimes they're not. And either way, it's important to surface them and get all those assumptions out on paper so that people can know what needs to be tested and understand really what they're trying to do. It's also a great way to identify where there might be disagreement among stakeholders about why an intervention is expected to work. Lots of times people have some assumptions about what's going to happen and why, and it's a great, working out an intervention theory is a great opportunity to sort out those disagreeing assumptions. And the purpose of the intervention theory, as we mentioned before, is really just to connect. If we do this, then this will happen in a logical, coherent way. And then the practice or exercise of doing intervention theory surfaces any kind of illogic that might be kind of creeping behind the, behind the assumptions. So, as I mentioned earlier, really the intervention theories are excellent at surfacing disagreement, getting people to agree, bringing people to consensus about what an intervention is trying to do and how it's expected to work. Once we get past the intervention theory and we know what we want to implement, we then quickly start thinking in terms of what questions we want to ask of an intervention. What do we want to know when we're done with it? And the way the analyst begins approaching these questions after the questions are first put on paper is to do kind of an assessment to see if those questions are something that can be answered with quantitative data or with qualitative data. I mean, we really do something we call an analyzability assessment. Is this something that can be analyzed with the methods that we have available to us and the data that we might ever have available to us? So the analyst is going to say, does the intervention theory make sense? Is it coherent? Is there reason to believe that if you do this, then these other things will happen? Is the intervention fully operational? This is a real problem when it comes to collecting data around interventions. Interventionists often want their data available on the day they start their intervention. And so the challenge there is that data are usually not available then. Even if data start flowing and start building into the system, they're not really analyzable until you have a certain amount of data, till you have maybe 50 cases or something like that. So aligning the expectations around analysis with the reality of what data are going to be available, and if those ultimate outcome data are not available, putting in some intermediate or process measures right away so that people can start getting the data they need in order to refine the program. Can you get the data? This is something we ask all the time. Even if the data are in the EMR, we think the data are available to us, but often they're not for a lot of reasons we've talked about already, and some we'll talk about at our next session. Are they reliable? Are they valid? Are they data that we can know when we pull them and do an analysis, they're telling us what we believe is the truth? Can you get a baseline or a strong control? And we're going to talk about this today. How do you think about a comparison? If you collect data on an outcome and the outcome is 2, how do you know that 2 is higher or lower than it should be? How do you know that you're hitting your benchmark? And can the things the stakeholders want to know be measured? Sometimes the things we want to know simply can't be measured at all. In healthcare, lots of times we want to look at patient satisfaction, which is a really, really important measure. It's really hard to get patient satisfaction in a way that could really answer our questions. Sometimes when we measure satisfaction, it's so far after the fact that there's all sorts of contaminating experiences the patient probably had that will affect their patient satisfaction scores. Sometimes in healthcare, sometimes one event in a patient's healthcare experience can really overshadow the others. Sometimes satisfaction really reflects gratitude on the part of patients. So just unearthing and pulling apart what that satisfaction means, and knowing that if you're really measuring satisfaction, and that's really key, how do you get that in a really precise way so that you know you're moving the needle on it? Is there enough volume? We need to have 50 cases for most statistical methods. So interventions that target very, very small populations are really hard to use quantitative methods with. You can use qualitative methods with those, and those can be very, very rich and helpful, but you can't really use quantitative methods with smaller populations. And then finally, something we think here at the hospital is the intervention worth investing analytics resources in, and how many of those resources. So it could be a small intervention that is a wonderful intervention and really impacts the patients, that impacts in a very significant way, but in the context of everything else the hospital is trying to do, there might be a decision that the amount of analytics resources the program team imagines having is just not realistic. So trying really hard to fit the analytics effort to the priorities of the organization, and trying to think about how to be efficient with those resources so that we're able to support as many projects as we can with a fair amount of precision. So today I'm going to hit some tough topics. I want to spend some time talking about validity and reliability, and I want to think about these from a researcher's perspective. As I mentioned before, my goal here is not to turn anyone into a researcher. but it's to kind of surface the assumptions we make all the time when we're making comparisons. And I think researchers just do an excellent job at thinking about comparisons very explicitly, and so we can learn a lot about how to be good comparers by just hearing how they do it. And I think that there's a lot in how researchers think about making comparisons that can be really quite helpful to operational leads and managers. So again, don't want to turn every project into a research project, but want to make explicit the assumptions that we are making when we make comparisons so that we can make them with more precision. So there's two types of validity researchers talk about, and both of them are very important. The first one, internal validity, is probably the most important for managers and operational leads trying to make improvement in hospitals. The first one, internal validity, is a method of comparison that allows you to know that your intervention truly did make a difference. And it helps you get to a point where you can say we have sufficient evidence to do that. It's not just my instinct, it's not just the feeling of the staff, but really we have enough data to say, yes, we moved the needle on something important. External validity has to do with whether or not the findings you have from your intervention can be applied to another environment. Lots of times researchers think about this as, doing an intervention in one hospital and then taking it to another hospital and another hospital and another hospital. But really the way we would think of it within a hospital is doing an intervention in a clinic and then applying those same methods to the same intervention in another clinic. It's really up for grabs to me a little bit the extent to which that can happen, but I think it's an important thing to keep in mind, because sometimes we do have an expectation that an intervention we put in place is just going to be tried out in a couple of clinics and will then be replicated in other clinics. And if we don't really think about external validity, that replication process can be very, very difficult. We need to think about it ahead when we design our intervention to begin with. So when we think about internal validity, there are 7 threats. That's the language researchers use to internal validity that researchers really dwell on. And these have been developed by researchers over the last 50 years. And I think almost all of them apply in our intervention work. I looked at them and I was trying to think through which ones I could exclude because they don't really fit an intervention environment. But I couldn't, with each of them I could think of a situation in which we could absolutely use them. So, or have to be worried about them. So the first one is history. History is, the history threatens validity in that there can be an external event outside of your intervention that shapes the entire intervention. So an example of this would be if you are testing a medication, the efficacy of a medication, and over the period you're testing it, a brand new therapy comes on the market that is really, really effective, and all your patients migrate to that new therapy. Now, that's not something you could control, and it would be unethical to control if it was a good therapy, but it would totally throw off your pre-test and post-test because you've got this huge historical impact on your comparison. The second one is maturation, and this is something we think about all the time in pediatrics, that sometimes you can do a pre-test and a post-test, and the difference in the score on those two things is just that the kids got a little older and developed more. And so in pediatrics, we are really laser focused on being able to adjust our comparisons to make sure that we take into account developmental changes that children go through naturally. The third one is testing effects, and this is something having to do with the environment in which the intervention is being given. Technically, these are really, really focused on surveys and the impact of surveys, taking a survey repeatedly over time and how that might change a respondent's reaction to the survey. It might change how they fill out the survey. But there can be other kind of testing effects as well. And so we need to kind of keep those in mind too. Those might not be relevant for every type of intervention we do, but they certainly do show up with some. Instrumentation changes has to do with the notion of changing what your pre-test and your post-test. So your pre-test and your post-test, whatever they are not consistent. You might have a situation in which you create a pre-test to observe 4 different phenomena or 4 different domains in a patient's experience, and then if your post-test doesn't match those or changes the measurements in them, it's very hard to do a comparison. So if you do a depression scale at time point 1 and do a depression scale at time point 2, and they're different scales, then it's very, very hard to know whether or not there was a change in depression, because it could have been attributed to the fact that you changed the scale. Selection bias is something that does and doesn't affect interventions done in healthcare settings. Selection bias has to do with not being able to, with a certain group of people choosing to be part of the intervention, or the intervention being set up in a way that only certain people really get access to it, and that can change your outcomes. So, for instance, if you have a program that's voluntary that you allow patients to opt into, and it's a better program to improve services, then your results are going to be affected by the fact that your study subjects will be people who are more motivated to get the intervention, and that can really play with your results of the intervention. That's one of the reasons we like random selection so much in research, because it takes away that kind of bias. There are so many ways selection bias can get into a study, into an intervention, that you always have to have your eyes out for it. But I also have to point out that many times in intervention studies, especially quality improvement, we really don't care about selection bias, because we just want to improve the services for everybody who comes to the clinic. So it doesn't matter to us really who they are or how that might change the intervention. We want the intervention to work right for them. So there are some times where you don't really need to worry about selection bias, but there are times you do. Experimental mortality, which is often thought of as attrition out of the study, is something that we also worry about a lot in intervention studies in healthcare. In a regional specialty center like our hospital, one of the challenges we have is that our patients come here for a part of their services and will go back to their primary care provider or to another specialist even in another city for the rest of their care. And that makes it hard for us to be able to include them in an intervention and really know what their outcomes were. So we might lose the outcome measure on a unique set of patients that have unique challenges in getting their services. And that might affect our outcomes. So we need to think about not just who gets into the study, which is selection bias, but also who leaves the study early, and that's attrition bias. Finally, the last one I'm going to talk about is a Hawthorne effect, which is very similar to the placebo effect, which is a well-known idea to healthcare providers. And the Hawthorne effect really, what it means is that when a person is in the study, somehow their behavior or their outcomes change because they know they're in the study. The best example I have of this is I was working with, this is outside of healthcare, but I was working with 2 schools and comparing them, and I randomly assigned them to the intervention and the control group. And when the control school found out it was a control school, they said, well, we're going to do the best we can to outperform the intervention school. That's exactly what I did not want to have happen, because it made the intervention very, very hard to test. So for each of these threats to internal validity has a solution in the world of research. History and maturation, the way we deal with both of these problems is we use control groups, and we have a pre-test and a post-test design. And if it's a true research study, it will have random assignment to the control group. As I just talked about for the school comparison I was making. But there are other ways in a real world setting that we can rarely do random assignments. So sometimes we'll do matching and other kind of sophisticated comparison tool techniques. Testing effects and instrumentation effects, these are problems that can be really managed with a really good and careful review of whatever data collection instruments you're using, and making sure that you're not taxing your subjects with a lot more data collection than they can handle, and also that you're matching and really thinking carefully about how the data are going to be compared when you're designing your instruments, so that you can have crisp comparisons. Selection bias, like I said, is often not a huge problem for us, but it can be. And when it is, that's what the magic of randomization solves. Not all the time, but it gets us there. And when we can't do randomization, we can use some pretty sophisticated matching formulas. Experimental mortality. This is something we really think we put a lot of researchers use incentives for. In fact, I know some studies where the population they're studying is so difficult to pin down and keep engaged in a study that they spend a huge portion of their budget on incentives and engagement activity. For most of the intervention work we would be thinking about doing, we really need to think about just being able to track people after they leave our hospital, or using intermediate outcome measures that we can collect while they're still here. And then the Hawthorne effect is usually dealt with by blinding subjects to whether they're in the demonstration or the control group. So we spent a little time talking about validity as it relates to comparisons, but validity is an idea that also has to do with measurement, and I want to spend just a little bit talking about how that term, which is the same word, how it's applied in the context of measurement. And I'm not going to go, we could spend really all day talking about validity in terms of measurement, but I want to just highlight three concepts that researchers think a lot about, and that analysts do as well. So the first notion is content validity. And content validity is a kind of validity that measures the extent to which the metric you're looking at actually taps into what you want to know. So one of the things we like to look at is average time of discharge, or discharge by 2 p.m. in the afternoon. And one of our big challenges when we began that work was making sure we had this timestamps exactly right, so we understood when the orders for discharge were being given and when discharge actually happened. It was surprising when we started opening that up, that when we looked at when orders to discharge, the timestamp on orders to discharge was often put in, was often way different than we would have expected it to be. And so getting the data cleaned up so that we can, if we want to have this measure time from orders to actual discharge, we need to have both of those timestamps in the right place so that we know we're measuring what we think we're measuring. Criterion validity looks at how well the measure allows you to compare an individual to an external norm. This is really significant when it comes to using benchmarks, which we use a lot in healthcare. The CDC, for example, has set up data collection standards for looking at certain patient safety issues like CLABSI and CAUTI, and the reason they've set those up is that they want to make sure that when hospital A compares itself to hospital B, they're really comparing apples and apples. And so we spend a lot of time when we're thinking about benchmarking, are we collecting our data in a way that matches the way the external norm data were collected? For our hospital, one of the big challenges we have is using PHYS data, the Pediatric Health Information System, that's sponsored by the Children's Hospital Association. 52 hospitals participate in that, but I would say there's only about 10 or 12 whose data really are a pretty close match to our data. And there's a couple reasons for that. There's only about 10 or 12 hospitals whose patient base really matches our patient base. And second, the way we're paid, half of our patients are Medicaid, and the way we're paid is unique among some of the states. And so there's only a few other states who have a Medicaid program similar to our Medicaid program. We need to think about those things when we do benchmarking. And then construct validity is an important concept that really comes out of psychometrics. And what's important about it is that there are some things we cannot measure directly. We need to measure by measuring it through a survey or some indirect way. And so construct validity is a process of establishing validity for a measure and determining that it does measure that underlying thing. So for instance, to go back to the notion of depression, there's no way to ask a patient point blank, are you depressed, and know for a fact that person is depressed or not depressed. So psychologists have spent decades developing depression scales, which are a series of items on a survey that fit together and together hang together in terms of being able to represent what depression is. If a person scores high on that depression scale, it's much more likely that they are depressed. And if a person scores low, it's much less likely that they're depressed. But it still doesn't mean they're depressed. But it does measure, it does have the construct validity of tapping in to that deeper notion of depression that you can't measure directly. And then reliability, I'm just going to spend a few minutes on because it's not used as often in our intervention work in the hospital, as we don't think about it as much as the internal validity and the internal and external validity. But I wanted to tap into it a little bit because there are ways in which it can really affect our work and our ability to understand whether we've made progress on things that we want to make progress on. So reliability simply means that when you measure something, that a measure is reliable when you measure it once. When you measure it a second time, you're tapping into the same thing you measured the first time. So, for instance, I just was talking about depression scales. So a depression measure is reliable if the same person takes that survey, and the second and third time they score about the same when they're in the same state of mind. The way that works out in healthcare is that lots of times we're pulling data from the EMR, and the EMR, we may get one workflow may tell us that the wait time in a clinic is X. And when we go and apply that same formula for measuring wait time in Clinic 2, we might get a completely different wait time. And it might be because the way the workflows work in each of those clinics are very different. So that means we need a different metric for wait time in each clinic. So the extent to which a measure is reliable tells us the extent to which we can use it over and over again and still learn the same thing, that it means the same thing. And we have that problem a lot in healthcare, that it doesn't mean the same thing wherever we're measuring it, because our clinics and our healthcare processes are so unique to the patients that we're serving, and that's appropriate, but it also makes measurement quite difficult. Reliability is also very important to benchmarking. I mentioned earlier how difficult it is to get the criterion validity between two sites. Reliability touches on something very similar, and that is if you took the same measure in multiple sites, it would measure the same things. So if we're not being able to do that, we can't really do benchmarking. And I will say, just in general, for a hospital like ours, benchmarking is always going to be very, very challenging because our patient base is unique. There aren't many hospitals who care for the same patient base that we have, and our context, as I mentioned before, the payment context is not uniform across the country. Okay, now I want to spend a little time talking about making comparisons and the way that researchers do. And before we get into the precise ways in which researchers make comparisons, and I'm just going to talk about a few of them because these are the ones I've chosen that I think interventionists in hospital settings are most likely to have a strong interest in. I want to talk about 3 different kinds of studies that, and go back to that notion of learning health system and how there's 3 different types of inquiry going on all the time in a learning health system. And in our learning health system, we have we use these 3 types of studies the same way and they're kind of parallel to the 3 different types of inquiry. So observational study is a study in which you just pull the data on a group of patients. You're not really concerned about controlling the data. You're not concerned about isolating certain types of patients or managing or selecting certain patients to include in an intervention so much. And these are observational metrics, and observational studies are basically what we do for all performance metrics, pretty much, where we're not really interested in saying for this group of patients are we doing this, but we want to know for our whole organization, how are we doing across the board. We're not trying to manipulate or control anything to learn anything there. We really just want to have kind of a huge aggregate number so we can see the progress we're making in aggregate. Quality improvement uses observational studies almost exclusively, and are least interested in all the concerns around selection bias and attrition bias. They just want to study the real world as it is with all of its difficulties. Quasi-experimental studies are types of studies that program evaluators tend to do, and also some translational researchers, and also some quality improvement folks. It's very mixed, but generally speaking, mostly this is program evaluation work, and this is where we want to test whether an intervention is effective, and we need to do it in the real world. We can't have random assignment. We don't really want to manipulate that much of the context because we want to make sure whatever we come up with works in the real world. So we really want all the bumps and unpredictableness of the real world, and we still want to test the efficacy of the intervention in that complex environment. And then the clinical researchers and translational researchers are more likely to use experimental methods where they really do control the context of the intervention very carefully, and will try to do some randomization, and they want to know whether it's whether the intervention, whatever they're testing, is efficacious. They can really only do that with randomization. So this is a table that kind of brings together the 3 elements of the learning health system that we learned about in the first session, and the threats to validity, and how each of those different modes of inquiry call on and how they address the issue of validity to the extent that they do. So this is a little bit of homework. I'm going to show you some designs, and I'm going to use a certain nomenclature that researchers use. I'm not teaching you this to give you a whole new thing to memorize. I think it really helps make the comparison process very crisp and clear. And so I think it's worth learning this. So an X is the treatment, an O is the observation moment, R means that a group was randomly assigned, and M means they were matched. So the first one, just as an example, is we're going to do something that we actually almost never do, and that is random assignment to one group, and the group. So each row is a group, and R at the beginning means that the people were assigned to the group in a random way. O1 means it's the first moment of observation. X is the intervention, and O2 is the second moment of observation. So if you're going to do a pre-post study, you would compare the first moment of observation to the second moment of observation and be able to draw some conclusion about whether or not the intervention had an effect. So that's just an example. So that previous slide showed randomization to a single group. It's pretty rare that people are randomized to a single group. But lots of times we can't do everything we want to do in terms of randomization in a real world setting. And we really still need to know whether we're making an impact. We need to know whether we're moving the needle. And so while we wish, I think, in a lot of ways that we could do that by just using observational studies really don't allow us the kind of precise and robust comparison we often want in the end. We might say going into a study, it doesn't matter, we want to see if this is working, we want to just see if we're making any difference. And if in the end we see a big difference, we're going to wish we had done some matching or some deeper comparison and we had set it up like that to begin with. So it's worth kind of dwelling on how to use quasi-experimental designs in a real-world setting, even for quality improvement and process improvement. Sometimes the nature of those, absolutely, it does not go with the nature of those, but other times, in the end, you want us to be able to say, hey, wow, we showed that we did move the needle on this, but do we really know we were successful, or was something else happening in the world? For instance, we are in the process of assessing whether there was a change to our hospital charges as a result of implementing clinical care guidelines. That wasn't anticipated ahead of time, and we're doing it now. And one of the questions our finance folks want to ask is, how can you assure me, because this goes over like 4-year period, how can you assure me that the changes in these charges are not related to other things, to the way Medicaid has changed and moved from a fee-for-service into a managed care program. So we need to figure out how to set up a comparison post hoc that allows us to rule out that the changes, the cost savings as a result of the clinical care guidelines are related to Medicaid managed care. So sometimes you don't think you're going to go there, but you end up there in the end. And so it's wise to think just a little proactively about it when you're setting out your work. So the first quasi-experimental design I want to talk about is a pre-test, post-test design, the one-group pre-test, post-test design. This is most often used in quality improvement and process improvement. And in fact, statistical control charts, really, this is the foundation of statistical control charts. You're not selecting one group, you're just accepting the group that comes to you. You're doing something different to that group, and you're testing them afterwards, or you're testing the situation afterwards to see if you've made a difference. The way it would work in quality insurance, quality improvement, is that it would look a little bit more like this, that you would be collecting data for every week or every month or every day in the clinic leading up to the change that you're making, and then you would be collecting it every week, month, day after that, to see if there was a change in behavior or in outcomes or whatever variable you're looking at. Excuse me. The way this would actually look for quality improvement would be a process control chart, which is what I'm showing you here. And the idea being that each of the time points along the bottom of the graph relate to an observation point in the pre-test, post-test schema. And the red line relates to the X, which is the moment of intervention. A second quasi-experimental design that's very, very useful in our settings is the pre-test, post-test match group design. This is one where sometimes you might do an intervention on one floor of the hospital and not do it on another floor, and see if the change was, at time point 2 whether the two floors were different. Matching is really important here because each floor has its own dynamic and its own patient base, and depending on the intervention you're doing, you really need to think about whether those floors are comparable. The reason you collect that first time point on both floors is so that you can know whether or not they're comparable, and when they're not, the degree to which they're not comparable. Sometimes this might be used for quality improvement, process improvement work, but it's often used for planning, and the notion of benchmarking is essentially lays behind this notion that if we can't get a good control group within our own organization, we might look at a national benchmark to compare ourselves for point 1 and point 2 to see if we make improvement compared to the national benchmark as it changes over time. A third sample, a third quasi-experimental design that I think is very useful for clinical settings is the separate samples pre-test, post-test design. This, again, is a design we use a lot, and we don't even really know we use it. We don't think about using it, but we do use it. And the more we think about what's involved with using it, we might be able to make our comparisons a little bit more precisely. This is a great design to think about using when you're doing a very short-term intervention with patients that maybe they would only come to your clinic 2 or 3 times, and you're not going to really be following up on that group of patients. So the first group would serve as your baseline for your second group. So the first group would come in, get their intervention in a short period of time, and then you wouldn't have a chance to do a post-test on them because they're gone. They've already moved on and they're better. But then you would implement the intervention with a second group. You would not have a pre-test for them, and then you would do a post-test with them. And you could actually do this, so then you would compare the pre-test and the post-test, and you would determine whether or not you have made a difference. That really only works if you have random assignment to both groups or you have matched groups. I also want to say that you can lay this out. Lots of times we do implementations. We start in 1 or 2 clinics, and then we go to a second clinic and a third clinic and a fourth clinic. And this is actually a great way to kind of stagger those comparisons over the different clinics and observe whether or not you're making a difference as you move through each of the clinics. And then finally, factorial designs are a great opportunity for healthcare settings. Lots of times we want to do an intervention that might be very, very complicated and might not know which part of that complicated intervention really makes a difference. Factorial designs are a way for us to piece out that intervention into different segments and identify which of those segments is the most efficacious. The way I've seen factorial designs used is where, and it can be used a variety of different ways, but the way I've seen it used is where you might, X1 might be the whole intervention, X2 might be the whole intervention minus one maybe really expensive part, and X3 might be an even more simple version of the intervention. And you might run these 3 interventions simultaneously in different clinics. Presuming your patient base or your clinics are matched well, you can then determine whether or not you need the whole intervention or just a part of the intervention to be effective. I think it really helps hospital planners identify the best way to use their resources and understand in depth, if nothing else, in depth why an intervention is working as well as it's working. So that's all I have to share with you today. Thanks very much. And I'll see you next time.